My experience has been that there is no overriding need for primary stability when placing a Bicon implant. I like to say this is a leap of faith, but if you're familiar with the Bicon system, you realize this to be true. The obvious scenario when there is no primary stability is when I place an implant into an immediate extraction site, particularly molar sites or molar sockets. I prefer to place implants immediately in extraction sockets whenever I can in order to optimize soft tissue and bone volume. Very often, the diameter or void of the empty socket is larger than that of the implant. The Bicon system works very well for me in this situation, where the implant can be placed single stage with a healing abutment. My goal is to place the implant not necessarily into one of the root sockets, but into the actual center of the socket. I use the healing abutment to help align the implant so that it remains in the middle of the socket. I will use autogenous bone, harvested from the socket either alone or mixed with an allograft, to help keep the implant abutment complex centered. Without a doubt, there can be significant mobility of the implant initially, but in time it will stabilize and integrate, and is usually loaded in 3 to 4 months. The use of a healing abutment at the time of implant placement will eventually allow a nice soft tissue profile and eliminate any need for surgical uncovering at the second stage, making it obviously easier for the patient. I tell colleagues that placing a single-stage Bicon implant is one of the most predictable things I do. I'm not advocating that everyone should do it this way, and on occasion there are those real failures, but it does provide obvious benefit for the patient, limiting the number of procedures. I can't do this with a screw-type implant in a predictable manner, period. I'm in private practice, and I place between 300 and 400 Bicon implants a year. If this didn't work and was not predictable, my referrals would send their patients elsewhere.